Good afternoon, everyone. My name is Terry. It's my face right there. I'll be my own personal Vanna White, don't worry. So today we have a really great panel, right? It's all about a question of access and quality healthcare in New Hampshire. I'm super excited for it because my arm has been in this brace for like 4 weeks, and I've been going through the whole healthcare system, and I hope somebody on this panel tells me what I should do differently to access the healthcare, but it's whatever, I'll get through it. Hey, no, Mom. Sorry. Anyway, but times like this, when you're really trying to connect with the community and you're really getting into these tea talks and you're really searching for some type of access to this education, it's really heartening to know that these things are put together by our really generous sponsors like New Hampshire Humanities, and particularly for this one, Wentworth Douglas Hospital. As well as the libraries that have partnered with us to make this possible. So we really want to give a hand for them, and thank you for their generous support. So with that being said, and that whole interaction being done, do you have anything else, Mother? No? Okay. Anyway, I'll turn it over to our moderator, Joe Porter, who is the Chief Strategy Officer for New Hampshire Center for Justice and Equity. Please give her a round of applause.
Thank you very much. I appreciate that. I'm wishing I brought my mother. I'm just kidding. Yeah, I'm just kidding. I actually don't wish I brought my mother. So don't tell her I said that. Although if you call me Josephine, I will think I'm in trouble with her. So everyone else calls me Joe. Okay, so anyway, thank you for taking time on a beautiful, albeit cold, Sunday afternoon to join us. Thank you to the Black Heritage Trail of New Hampshire for giving me the privilege of getting to facilitate this panel of experts, some of my favorite people, to talk about one of my favorite topics, which is healthcare access and quality. Each of the panelists is going to take a few minutes to introduce themselves, so we'll let them do that in totality in a minute. So right now it's just about me. You're welcome. And it probably says a lot about me that I will tell you that in reality, this really is one of my favorite topics. I talk about it all the time. I talk about it at home. I talk about it with my teenage children, which, as you can imagine, goes over really well. But I hope that any of my fellow policy folks in the room, and I know they're there. Okay, I'm not going to call her out, but she just saw me. And on Zoom can attest, once you are bitten by this health policy bug, it is hard to recover. So you might not ever, and if you don't, that's not my fault, or you're welcome, whichever one makes you feel better. And I do hope that you find that this is the start of a conversation, because we are not going to fix this issue in the next hour and a half. I really wish we could, and if we could have, we should have done it a long time ago, because just as we learned, every single person who we talk to says, I got something to tell you about the healthcare system. So we're gonna dig into a little bit of that, and we certainly can't dig into all of it because we don't have enough time. But that being said, I thought maybe what we could do is start with the actual quote that was part of this session description, which is the right to adequate medical care and the opportunity to achieve and enjoy good health. It was one of the fundamental rights of Americans. So I don't think there are too many people who would argue the validity of access to care and good health is fundamental to well-being and what we should be all able to achieve. I don't think there are that many people who would say we've been able to achieve it. And one reason is because we don't actually know what we mean when we say these things. That is, we don't have consensus about what adequate medical care needs, nor is there a universal definition about what it means to, quote, enjoy good health. But I do think most folks would say, I'm not sure we have either of those things in the bag just yet. So when we ask ourselves the first question, have we ensured adequacy of care? Spoiler alert, no. No, but there is good news, right? The good news is that if we use the definition of having an actual insurance card to be able to try to get care, Our benchmark around that has been going well. We are doing better than we've ever done in the past. And for those that you know me, as much as I'm a policy geek, I am a data geek even worse. So let me share with you a little bit of data. So the national uninsurance rate hit an all-time low in 2022, according to recent data. The Kaiser Family Foundation reported that in 2022, 9.6% of the population nationally under the age 65 was uninsured. That's a really good rate compared to our historical trends. In New Hampshire, that number was about 6%. So while that's all really good news, what we know is that the highest rates of uninsured have historically been and continue to be among our communities of color. So while we are closing the gap, we are closing the gap more slowly in certain populations. So nationally, that number is 6.6% of uninsured under 65 years old among whites, 10% among Blacks, and 18% in a Hispanic population. And while those numbers, again, tend to be encouraging in their trends, what we also know is that having an insurance card does not mean we're getting adequate medical care. Okay. In fact, according to more data, you're welcome. According to survey results from the Commonwealth Fund in 2023, the percentage of people who were insured yet delayed or skipped needed healthcare or prescription drugs because they couldn't afford it in the past 12 months ranged between 29% and 42%, depending on what kind of coverage you have. The highest percent, that 42%, were people who have Medicare. I know, I'm such a downer. I'm so sorry. It's gonna be good though. So I think we can all sort of attest to a number of factors that show us that we have not yet achieved adequate medical care. And when we think about the enabling environment to achieve good health, one would ask ourselves, have we achieved that either? Spoiler alert, no. But again, we are trying and we are making progress in some places. Earlier T-Talks in this series focused on economic outcomes and housing. I would encourage you, if you haven't, to listen to those as well, because those are intricate parts of good health. These are not unrelated items. I won't reiterate those here, but I would say that all of these are related items. And when we think about more traditional health outcomes, the same Kaiser Family Foundation also has reported that life expectancy, infant mortality, and food insecurity are worse outcomes among populations of color across the United States. And here in New Hampshire, as part of a state health assessment, state health improvement plan, with full disclosure, is a group I facilitated. So I have to just say this isn't random. And both Bobbie and Marie and some folks in the audience who I'm also not going to call out were actively involved in that work. But I will say that one of the things that we did for New Hampshire was to survey different populations and ask about their health perceptions. And one of the things that we saw in a major differential was that while 33% of non-Hispanic people noted that their physical health limited them in everyday activities, 55% of the Hispanic population indicated that physical health limits their everyday activities. So all of this is to say that we have work to do, and that sets the stage for the conversation that I'm going to ask my esteemed colleagues to help us work through, to find out where we can go from here, how we're doing, where our successes have been, and where we continue to do good work. So with that, I'm going to introduce the panel. I'll name each of these folks, and then over the next 30 minutes, each of these amazing women who I'm lucky enough to be sitting here with are going to talk about some of their work, some of their reflections, and then we'll go into question and answer. So on the panel is Bobbie Bagley, Chief Public Health Official in the City of Nashua, Dr. Marie Ramas, who is the Regional Medical Director of Aledade, and Nicole Sublett, who is the founding president and major lead provider at Nicole Sublett Counseling Services. Did I get that title right?
Yeah, I've actually changed the name. It's a rebranding, so it's now Therapists of Color New England, and it is the first all BIPOC mental health practice in the state of New Hampshire. And currently there's 6 clinicians for the practice.
Great, thank you. All right, so Bobbie, I'll hand it to you.
All right, good afternoon. And thank you again, Black Heritage Trail, for having me participate in this Tea Talk. I am very excited to be here and looking forward to a good discussion. So as Joe said, I am the Chief Public Health Official, and I'm the Director for the City of Nashua's Division of Public Health and Community Services, which is one of the 2 fully functioning health departments in the state of New Hampshire. We are the only accredited health department at the national level, and just completed our 5th year for reaccreditation, and so that is a huge accomplishment for our state. It's a really arduous process to get accredited, but hey, our schools are accredited, fire departments are accredited, hospitals are accredited. Shouldn't our health departments be accredited as well? So yes. Yay, Bobbie! Huge feat to get accomplished. Not something that's done alone, and without the health department staff, as well as the community partners, Board of Health, our aldermen, all play a role in that, as well as a number of our partnering organizations. And so the work that we do at the health department and what I lead is we serve and sit as a chief public health strategist, not just for Nashua, which is, like I said, the 2nd largest city with a population of about 91,000 individuals, but we also work regionally. So we provide services for the 12 surrounding towns. So that makes our catchment area about 215,000. So it includes Hudson, Litchfield, I'm probably not gonna name all 12 of them, Merrimack. Anyway, so the 12 around. So if you go on the map, you look around there. We even go all the way over to Pelham and as far up as Lineborough. And so those are the services that we provide. And it's through funding that we get from the state, as well as that's passed through the CDC and through SAMHSA. So the work that we do focuses around addressing healthcare needs and making sure that we can provide information out, the majority through health promotion and communication, so that we can have an informed community, so they can make the best decisions around their healthcare. And so it's always a challenge, because one of the toughest things that we deal with in public health is human behavior and getting people to change their behavior so that they make really good health decisions. So we look to provide information so that folks can do that. For this afternoon's Tea Talk, where we're looking at, the question around quality healthcare and access, Joe gave some statistics that are really good. So it does show us moving in a nice direction of getting more and more people insured, which is great.
Good.
Through the Affordable Care Act or the marketplace, we've seen the number of folks actually getting signed up for insurance increasing. As Joe also said, that's not like the end all and be all in the game for us, because although a person may have an insurance card, whether it's Medicaid, Medicare, or their own private insurance, the biggest issue that we've seen, as much health promotion information as we're putting out so that people can make really informed decisions, sometimes when it comes down to that primary care that they may need to get to with that insurance card, they don't always have access in a timely manner. And most of that is because of the workforce issues that we're facing. And that was pre-COVID that we were having some issues with workforce, in particular in nursing. My background is in nursing. I'm a public health nurse by training, as well as having my training in public health as well. But get to the doctor's offices, getting mental health services. So I am really excited about what you have opened up, and we will be in touch. That has been a challenge, and the barriers have been mostly, again, related to healthcare workforce. We've had the opportunity in Nashua to take a little bit of a deeper dive to try and understand, in particular with BIPOC populations, what have been some of their issues with quality healthcare and access. And I'm going to share a quote, because this is Black History Month, so I'm going to just dance on that stage, from Reverend Martin Luther King, Dr. Martin Luther King, that says, "Of all the forms of inequality, injustice in healthcare is the most shocking and inhumane." Because although we have had all of these great strides in moving things forward, we still have populations or individuals and population groups that are still having barriers for them being able to access healthcare, whether they have an insurance card or not. So we took the opportunity to learn a little bit more about that, especially after COVID. You guys remember COVID? Who doesn't remember COVID?
This little thing.
But during COVID, we had the opportunity to learn, how much of the disparities existed in our communities, and in particular in BIPOC populations, Black, Indigenous, and other people of color populations. COVID just shined, like how this light is shining up here on us, it shined a really bright light on the issues for individuals. Again, insurance or not having insurance, it just showed us how much of a problem that we have within our communities, or people actually having access. So we actually had the opportunity to gather some folks together safely and ask some questions of folks with regards to their having access to healthcare, and then some of the challenges or barriers that they actually faced. So we had about 35 participants that represented Black American, US born Black Americans, African new immigrants to the greater Nashua area, Portuguese speaking Brazilians, and individuals that represented Spanish speaking community, which were Latinx, so they could have come from different Latin American countries. And of the 35 folks that participated with us, 69% had access to healthcare, which is good, right?
Good,
So we
very
can get that number up. But some of the other things that they talked about were interesting, because this also showed us things that we needed to work on to try and improve that. Language was a number one issue. And so I've been doing this work now for I've been in New Hampshire for 32 years, and I've been doing this work for about 26 years. And that was an issue 26 years ago. So we're still addressing some of the same issues. We're trying to get a little bit better. We've made some headway by making sure that we have individuals in the workforce that can speak the different languages as their primary language for individuals in accessing healthcare, but they're not always in the healthcare setting too. So a lot of information still goes out in English. A lot of the folks that folks will interact with when they go into some of the healthcare setting may be English speakers primarily, but we are starting to see more individuals that represent Spanish-speaking populations, which is great. Not so much for Portuguese, and not so much for some of the other languages that we have, Swahili. Although New Hampshire is big French-speaking, we don't have big French speakers in some of these settings as well. And so we have been working towards trying to close the gap and make sure that folks can have connections to the services, especially if they have access. So we've been able to hire community health workers whose first languages may be Spanish, Portuguese, French, Swahili. We have a team that speaks 9 different languages. And so that helps to increase that challenge. But some of the other barriers, and hopefully we'll get to talk about this as we go on, also include the lack of trust that folks experience when they're interacting with the healthcare system as well. And so just to give you a kind of like a little bit of an overview of where I sit and the work that we've been doing and what we've been looking to do intentionally with population groups, getting out and actually hearing from folks, because we found that in some of these listening sessions that we had, and we did this work with New Hampshire Listens, and so I saw someone from Carrie from New Hampshire Listens. We're going to talk about some of the work that we've done together. We found that what people want is they want people to listen to them, and that's been a challenge as well. So you're not going to get quality healthcare if you're not being heard. You're not going to get quality healthcare if the issues that are constantly being brought forward aren't being addressed. And our hospitals and our clinics, they're trying to do the best that they can to meet some of this need, but until we can address some of those workforce issues, we're going to always have this challenge. So I'm going to stop talking now so that Dr. Marie can talk.
Thanks, Bobbie, and thank you, Black Heritage Trail, for inviting us to have this discussion. Just to give a little information about myself, I am born in Boston, raised in New Hampshire, graduate of West High School in Manchester. So I am a first-generation Haitian American and the first doctor in my family. And the reason I went into primary care is because I realized that the way that I grew up learning about health and wellness in a holistic fashion was not necessarily the system in which my family grew up in. And I didn't see many people that looked like me in the healthcare system. And so I wanted to be a voice for that. That started very early. Being a Caribbean person, I'm not shy when it comes to utilizing my voice. And with that, I've been able to work as a National Health Service Corps scholar and have done everything in family medicine you can think about. I like to tell folks I used to do Dr. Quinn medicine before coming back to New Hampshire. I'm dating myself. But I've worked with families from cradle to grave. And in the height of the pandemic, in addition to serving my community in the greater Nashua area, I had the tremendous opportunity and gift of being a voice for those who are historically minoritized in the state. How do we communicate effectively the work that's being done and change intention to reflect the impact that we're trying to create in public policy? So that's a little bit about myself. Currently, I am working as a regional medical director for a national value-based care organization called Aledade. And they are a physician-led accountable care organization that represents we are now 41 states represented. And my sole purpose in joining this organization was because I felt it was imperative that our Granite Staters had opportunity to have high quality access to care and have an opportunity to have an experience of focusing on not just reactive medicine, but having preventive medicine be of the center in a patient-centered way. So with that, I wanted to share a little bit from my perspective as a primary care physician, as a person of color, and one of a handful of primary care physicians of color in the state of New Hampshire, and how I've leveraged this perspective to both help on a local perspective and on a national standpoint. And I'm sure we'll have time to talk a little bit more amongst us in this tea time. So one thing that Joe mentioned was this idea of access to care. And very often when we think about access, we think about just having the door open. But we never talk about having people come into the door, right? So, a barrier of having high quality experience of care from a patient-centered standpoint is having the ability to walk in the door. So the door might not be locked any longer. But then there's that impetus of the patient to find the agency to want to desire to walk through the door, see value in that door, and then 3, trust whoever's on the other side to do the work that they need to do and partner with them. Very simple to me as a primary care doctor. What I'm realizing in the policy standpoint is not always straightforward. So when we think about these innovative ideas of how to address spend in care, how do we address poor health outcomes in populations? How do we address the disparities and the differences between different caveats of patients within the Granite State? We have ideas, but how do we implement them when we don't have people who are in the actual boots on the ground area to actually continue to perform the work? And so being a primary care physician who has been seeing patients for the last 15 years, who understands the implications of the decisions that are made on a higher level, and who can then translate my experience and my colleagues' experiences back to the policymakers, that is a rarity for lots of different reasons that we might be able to talk about just a little bit today. So that's one thing, access to care. It's bi-directional and it takes a partnership. The second thing is incentivizing good medicine. So, this probably is not a secret. America has the worst healthcare outcomes of all of its peers across the world. We have the highest cost and spend. One statistic I saw was that although America, US, represents about 15% of the world population, we utilize over 60% of the depression medications and medications for behavioral health in the world. So there's an issue there, right? Part of that is because, one, we don't have universal primary care access, and we haven't defined what that looks like. And 2, we don't have a preventive centered system We work on an a la carte basis in the healthcare system, meaning that you eat what you kill. You, not real, like, so I don't eat what I kill. But from a doctor's standpoint, you know, I have to bill for everything that I do, and I have to account for everything that I do at the point of care. And that's not why we go into medicine. We go into medicine because we want to change people's lives. We go into medicine because we care about the populations, the patients, the people that we love, and we want to make a difference. But at the end of the day, how many people go to your doctor's office and instead of seeing your doctor's face, you're seeing a nice profile, and what are they doing? They're tapping on a computer, right? Or God forbid, you're in the hospital and you can't even see your nurse's face because she's behind, you know, a computer, typing and registering and documenting. So we have a disconnect here. It is a thorn on the sides of your clinicians, particularly in primary care, having to check boxes instead of looking you in the eye and spending time with you and getting to learn about you. The biggest lie that people have, you know, come to, I think, believe, or it's been socialized, is that doctors aren't here for you. It's very, very, very beyond the truth. As a matter of fact, we're so much here for you that we're willing to deny ourselves sometimes humanity and time in order to do what's right and to continue to be present, even though it's not perfect. So how do we incentivize good medicine? When we're in a place of constant trauma, one, we're in trauma because we have to see our patients every 7 minutes, and we've got lots of things we got to take care of in 7 minutes time. And then we have to eat on top of that and maybe go to the bathroom in a 9-hour day. But then also we have the pressure of having to produce. So we've come into this place in medicine where it's changed from that good old family doctor with the black bag that goes to your house, which I used to do and I love very much. Go to your house, you know, get to know your whole family. I take care of you. I deliver the baby. I give the baby shots. I talk to mom, help with breastfeeding, help grandma who's, you know, starting to get a little bit, having trouble getting around the house, have family conversations. And now we're in a place of productivity. See as much as you can, as much as possible, because medicine has become a commodity. It's become a commodity. So we are in this place of value versus productivity. And my job, they don't know it at my job, so don't tell them at Aledade. My purpose in doing this national work is trying to bridge the gap, creating a value proposition in humanizing the experience of medicine again, and helping people understand that you can indeed meet mission with margin. And the way that we do that is by explaining that, one, health equity is not just a problem for those who are historically minoritized. It's actually everyone's responsibility, because we all benefit when we think about those who are least represented in our circles. The way that I've done that in very practical terms is, like Bobbie has said, we come up with these really innovative strategies. So in value-based care, we have, you know, all this, you know, marketplace with Medicare. You get Medicare Advantage now. You can get these like cool, you know, gift cards when you come in for your annual wellness visit, and that's great. Blood pressure cuffs. You have nurses coming to your house. Awesome. But even though these are available, sometimes the people that need it the most don't get access to it still. Why? Because we don't ask the question about who's not in the room. So one of the things that I did in the last year actually was think about and ask the question about how can we increase access to better blood pressure care. Blood pressure is the #1 cause of preventive morbidity or issues with chronic health. And it is often difficult to control and to help control for lots of reasons. So my company, as with many companies, they said, well, why don't we just get remote patient monitoring? Everyone gets a blood pressure cuff at home, and then everyone can show their blood pressure and they don't even have to come to the doctor's office. That's great. And then I asked, well, how are they going to upload their information if they don't have good Wi-Fi? And they said, well, what do you mean, Marie? Everyone has access to internet. And I said, oh, you don't live in New Hampshire. Broadband is a social determinant of health. What do you mean broadband is a social determinant? Well, many people don't live in areas that are making these decisions in areas that lack bandwidth, both theoretical and real bandwidth. And so we have to talk about, even though patients are maybe using telehealth, how are they using it? When I did a quick study about my patients in health center settings, we realized that when they were getting telehealth services from specialists, it wasn't from their home. They were still coming into their doctor's offices and logging in to talk to the specialist because they didn't have access to broadband and to internet. Nobody would have known had we not asked the question. Another way of incentivizing good medicine is understanding your audience. And so, it's human nature to think about what are you most familiar with? You get to see that more often. So if you buy a new car, what happens when you're driving around in the street? You see that car everywhere, right? It's the same thing in healthcare. If I'm used to taking care of patients that maybe their first language is English, I'm not always going to remember that all of my documentation and education is just written in English. Or maybe you speak English, but you may not have graduated from high school and your language proficiency is not at the same caliber as the medicalese that we use in the documentation. Who's your audience? And when you're working on a day-to-day basis, we call it at the point of care. So in a clinical setting, you're working so hard and you just gotta be productive. It's hard to think about those nuances. And so my job has been trying to figure out how do we automate processes and create processes and workflows so that we can all make the right decisions easier, whether that be the clinical team, whether that be working with our public health department or our patients, whether for them, how can they make the best decision possible for themselves, easiest, without barriers. The third thing I'd like to share is this concept of disruptive innovation. So with the State Health Assessment, State Health Improvement Plan, we've been talking a lot about what is the concept of health and well-being from a Granite Stater's perspective, but then also how are we able to create mechanisms and understand what's the ecosystem of access to other ways of care. How do we know in Coos County where to get the best food and clothing for our patients, or transportation when it gets really cold and snowy outside? That level of innovation is really important, but how you get there is very difficult. We're talking a lot about artificial intelligence. How do we use these algorithms that we use in social media to kind of perceive and identify habits and ways of communicating with patients? It's great, but who's developing those algorithms, right? If it's a person that does not necessarily share the same kind of experiences that we do, then we're gonna miss a whole cadre of people, places, opportunities, and experiences still with innovation. And so it is absolutely imperative, I think, for us to think about when we are developing programs and strategies, we have to think about how the end user, the clinician or the patient, how is that end user going to be affected by the decisions we're making in a policy level? One of those things is creating a healthcare consumer protection group or coalition to kind of look at policies in this Granite State and make sure that we're vetting some of the policy works that may have good intentions, but the impact may be a little bit different than expected. So having a group of subject matter experts in the Granite State who can look at policies with keen eyes on how is this affecting the quote unquote consumer or the patient. The last thing is this concept of focusing and refocusing back on primary care. Primary care, and I am completely biased, but the numbers support this. So primary care doctor, everyone needs a family doctor, everyone, but not just any family doctor. Everyone needs a family doctor that knows you. When there's a family doctor that's able to be in the hospital and able to kind of talk with the family and able to coordinate with specialists, not only does your experience get better, but the cost of care always goes down. Family doctors are the only profession and only specialty that saves the system money. So that is a great value proposition. That means that when I get into the room, healthcare companies, Medicare, they all have lower costs because y'all stay out of the hospital when I'm in the room, okay? So everyone needs to have a primary care clinician, physician that is competent, that has the time and the autonomy to do good medicine, and that has coordinated support to provide for you and to collaborate with you. Yes.
What I have found, I've been in the hospital recently because of an accident. I don't see my primary care. I see a hospitalist.
Correct. So I'm just going to repeat your comment. When we are now going into the hospital, we don't see our primary care doctor anymore. We see a hospitalist. I call that the fracturing of our healthcare delivery system. And that has been done. Listen, we make decisions and we create systems that create reproducible results, whether it's consequential or inconsequential. So it is becoming rarer for family doctors like myself to have the capacity to do what we call full scope family medicine. I was probably one of 2 family doctors in the state up until 2020 who was a community family doctor still delivering babies at my local hospital in the state. So the system does not necessarily support the same traditional type of primary care that we might have thought about even 10 years ago, but we have capacity now to create innovative networks and matrices so that you can still have a foundational ecosystem in which you work. And so it is really important that as patients, you are also advocating for your family doctors to create a matrix, an ecosystem that's going to be supportive of you. I believe that, and I will switch over to Nicole to talk about the behavioral health side, but I believe that although our medicine and the medicine that we're living in, this healthcare system we're living in, may not look the same as it did 20 years ago, we can still carry over some of the values, the experiences, and the priorities that make medicine sacred. We can still carry that through, but we have to, one, be disruptive. We have to be collaborative. And you have to remember that even as patients in this system, you have autonomy and you have decisions that you can make still. It doesn't always feel that way. But the more that we're able to activate and empower ourselves and work together and find people who speak our same language, I say that on purpose, you work together, you can still advocate and have a primary foundation of health, well-being, and equity. With that, Nicole.
Okay.
Thank you. Can you hear me? Is my mic on? Can you hear me? All right, beautiful, beautiful. So thank you, Bobbie, thank you, Marie, and also thank you to the Black Heritage Trail of New Hampshire. So my name is Nicole Sublette, and I'm a licensed clinical mental health counselor. And I could really talk about what I see in my field, which would echo a lot of the things that are being brought up here today. But I got really excited about this talk and presentations because it's called, Oh, the Stories We Could Tell. So I'm like, ooh, the stories we could tell. So I've come prepared to tell you a story. And I want to talk about the stories because we're talking about also exploring the inequities in healthcare for Black Americans and BIPOC folks in this country. So in order to understand why we're at today, we have to talk about the history of why we're at today. So I'm going to share some stories. So we're going to go back to the 15th century. Gomes Zurara. And my Portuguese, I'm sorry, is very phonetic. I apologize, but I'm going with it today. Gomes was a chronicler in the 15th century, and he holds a significant, albeit troubling, place in history as one of the earliest architects of racism. In 1453, Zurara published the Chronicles of the Discovery of the Conquest in Guinea. That's quite the name, but that's what he did. Zurara's work detailed the life and deeds of Prince Henry the Navigator and the Portuguese exploration of Africa. This chronicle propagated narratives of African inferiority, portraying Africans as subhuman, Zurara wrote, this black race of people was lost, living like beasts, without custom or any reasonable beings. They had no understanding of good, but they only knew how to live in bestial sloth. Zurara's chronicle was propaganda for African enslavement. The Christianizing and civilizing was the guise that the Portuguese used for the enactment of slavery. In Dr. Okongo Dibinga's book, Lies About Black People, Dibinga states, the system of race we use today was set up in the mid-1400s to justify the enslavement of African people. The lie racial hierarchies created to allow the Portuguese to go before the Vatican, to justify slavery as a means of saving Black savages, but not revealing the truth of their intention, that they wanted the endorsement of slavery for economic means. Dr. Ibram Kendi also looked at Zurara's publications, and he wrote an article, How Racism Relies on Arbitrary Hierarchies. Kendi states, despite different skin colors and language groups, Zurara blended them into one single group, people worthy of enslavement. Through Zurara's chronicles, a racial hierarchy was created. Kendi also goes on to say that Zurara grouped the people from Africa into a single race for that very reason, to create a hierarchy, which is the first racist idea. Race making is an essential ingredient in the making of racist ideas, the crust that holds the pie. Once a race has been created, it must be filled in. And Zurara filled it in with negative qualities that would justify Prince Henry's evangelical mission to the world. Zurara not only perpetrated negative stereotypes, but his writings laid the groundwork for the systemic dehumanization and exploitation of African peoples, which led to the justification of the transatlantic slave trade, and ultimately contributing to entrenched racism that continues to plague societies around the world today. John Bowen, Duke University's audio director, in a TED Talk said, racism didn't start with a misunderstanding. It started with a lie. Dr. Kendi reduces racism and the racist idea to self-interest. I'm enslaving people because I want to make money. Abolitionists are resisting me, so I'm going to convince Americans that these people should be enslaved because they're Black, and then people will start believing those ideas. That people are so barbaric that they need to be enslaved, or that they're so childlike they need to be enslaved. And this kind of drops into also, I'm bringing this up because it also drops into the field in which I work in, which is the field of mental health. 19th century healthcare practices were used to reinforce and perpetuate the economic interests of slaveholders while exploiting and disregarding the health and well-being of enslaved populations. American physician Samuel Cartwright coined the term drapetomania. Drapetomania was used to describe the supposed mental illness of enslaved Africans who sought to escape captivity and slavery. It was used as the justification of slavery. By pathologizing the desire for freedom and autonomy among enslaved people, drapetomania attempted to delegitimize their struggle for liberation and reinforce the notion of white superiority. This falsehood served to maintain control over enslaved populations and bolster the broadened American economy, which was reliant on slave labor. Exploitation of Black labor was reinforced by racist ideologies that persisted long after the abolition of slavery, contributing to systemic racism and the inequality in American society, the inequality that continues to be erosive to American society today. Past lies and stereotypes have had a profound impact on modern day health and mental health care for people of color. Historical injustices such as slavery, colonization, forced assimilation, and segregation have contributed to ongoing marginalization and stigmatization. This has led to disparities in health care and mental health services, misdiagnosis, which I can talk a lot about, inadequate treatment, and poorer health and wellness outcomes. The COVID-19 pandemic further intensified existing inequalities in healthcare, During the pandemic, people of color faced higher rates of infection, hospitalization, job loss, and instability. These stressors have taken a toll on communities of color. Access to adequate mental health care became increasingly challenging. Lack of insurance, language barriers, limited availability of culturally responsive counselors and physicians, and lack of internet access, which Marie talked about, or private spaces for telehealth were among the numerous challenges that disproportionately impacted people of color during the pandemic. Healthcare inequalities serve as an economic tool for those in power by perpetuating exploitation, profit-driven approaches, and prioritization of privileged populations and healthcare needs over marginalized communities. Limited access to quality healthcare ensures that certain populations remain in a cycle of poor health. Disparities in healthcare coverage contribute to unequal access to healthcare services. Individuals without adequate coverage often have to delay or forgo necessary medical care, leading to exacerbated conditions. This perpetuates a system where those who can afford insurance have better health outcomes and access to preventative care. Pharmaceutical companies may prioritize the development and marketing of medications that target chronic conditions prevalent in affluent populations, such as cardiovascular disease, certain cancers, diabetes, and obesity. Neglecting diseases that impact primarily marginalized communities, such as malaria, malnutrition, tuberculosis, AIDS, HIV, maternal diseases, and child health issues. Investments in advanced medical technologies, research, and healthcare infrastructure often prioritize affluent communities in neglecting the needs of underserved populations. In summary, our modern-day healthcare system exploits vulnerable populations, prioritizes profit over public health, and reinforces social inequalities. Healthcare inequalities serve as an economic means to people in power by maintaining social hierarchies and consolidating wealth and resources among privileged groups. As a Black woman and licensed mental health counselor providing service today, I witness the healthcare inequalities. I see the exploitation. I also live the marginalization and oppression, and on multiple levels, experience how these lies are kept alive today.
Okay. So it's very clear we probably have 22 tea talks that we could do out of this session. Why don't we open the floor? Carrie, do you want to give us some guidelines for this discussion? And if folks in the room don't have questions, then I'm happy to ask some.
All right, we're going to move into a question session. I believe there's some dialogue agreements. So we're going to ask that you just be respectful and use respectful language. Please use the microphone, so when I walk around, I'm going to balance my time between the audience and then checking in with Terry on Zoom. And so I'm going to kind of put the microphone near you so you can talk, and then I'll probably pull it away. Listen generously to learn, and share airtime. So we just ask you to be really crisp with your questions. We all love stories. I know I do. But we want to make sure we can hear questions and have the speakers respond to you, so just be very crisp with your questions. And don't interrupt one another. Be mindful that good intentions can still have a harmful impact, so again, be thoughtful about what you're saying, the words you're using. We'll just honor confidentiality, so stories stay, learning leaves. So we're ready for some questions. I'm not sure, we usually start in person or online. Okay. Okay, great. Okay, I'm gonna go right here.
Hello. First, thanks to all the panelists for coming up. Found it to be a really good conversation so far. Just out of everything that everyone said, and I'm not a healthcare professional by any stretch, but I think I'm thinking about, is particularly what Nicole spoke to at the last part, is first of all, acknowledging the power differentials of racism that exist in these systems. And I guess I would just more ask if anyone can respond to how lived experiences are incorporated into these conversations. I'm a lived experience geek, so I'm a qualitative researcher, so I have no interest in quantitative analysis at all. But this would be just a really interesting conversation if the people in the audience were healthcare professionals and the people on the panel were lived experience, people who don't have who are the nameless people you're talking about. I guess if you could just respond to those power differentials, how that fits into your work to be able to change policy, because it's not, otherwise it's still pathologizing people and their human behavior and not really listening to when they say, I got to make a decision between food and trying to get to the doctor today. So.
Could I start with that? Like your question, you were speaking, I was nodding, I was shaking my head because I feel that question so much and in so many ways. I developed my practice, therapists of color, because of lived experiences. I found that when I was in solo practice by myself, a lot of my clients of color, and particularly my Black clients, were always being gaslit in therapy. And they weren't told that their experiences were legitimate. And so I developed my practice so we could actually create a sacred place and hold those stories safely as much as we can, because there's really no such thing as a safe place. But you're right. One thing that I fight against day in and day out is pathologizing. And so I think about consistently the way that we diagnose folks, and also, more importantly, what the insurance companies see as a medical necessity. So if someone comes to me and they're struggling at work and they're experiencing racism and they're experiencing oppression and marginalization, we have codes in our DSM that say person experiencing alleged racism. It's kind of the vernacular there, right? But I cannot use that kind of code. I have to find medical necessity. So I might have to diagnose someone with an adjustment disorder, an anxiety disorder, a depressive disorder. So therefore, perpetuating the system of oppression. We understand how oppression works on multiple levels. And what it does is that it further increases internalized oppression, because it now becomes a them problem and not a systems problem. And I face that all the time as the own battle within myself is, how do we change this? How do we change this policy? Because the insurance companies want medical necessity and people need help. That's beyond just medical necessity. So I just wanted to answer that because I was just feeling it.
Yeah, I have to double click on that. It wasn't until recently that the connection of weathering, and meaning those who have historically endured and experienced systemic racism throughout their lives, how that changes DNA. It actually changes your DNA, meaning that the internalized and experienced racism that my mother, my grandmother, my grandfathers, my great-great-grandmothers and fathers and aunts and uncles, that has caused actual changes in my cell structure. It's called epigenetics. And so we didn't even have that terminology in medicine. Why is that impactful? Now, on the national standpoint, I can go back to the American Academy of Family Physicians, and when they're talking to the Medicare directors, they can say, listen, racism is an issue. It's a public health crisis. It's a problem, and we need to be able to document it in a way that's going to express the lived experiences of our patients. And so now, Medicare, Medicaid services, health insurance services, now they've developed codes that we can actually document what they call social determinants of health. We're calling it systemic structures that affect a patient's experience. And now they're starting to look at what are the correlations between these quote unquote high risk, I like to call them prioritized populations, and the lived experiences that they have that are not medicalized. So it's a start, it's not a complete answer.
Bobbie, do you want to take a little bit of that from the public health
and I
side?
was going to say, at the local level, see, we're boots on the ground, so we hear the stories every day. I will get the call, like if a person goes to their doctor's office and there's a circumstance that they feel like they're not being heard or their needs are not being met, we'll get the call. I'll get the call. And then what I'll do is I'll follow up and try and work directly with the provider or the the organization to try and figure out, so what are some steps that can be taken, because you're not actually really hearing what your patient or what your clients, what they're saying and what their experience is. So we're boots on the ground. So we have to do a kind of mix of the anecdotal stories that we hear and then put it into a format so that it becomes like qualitative data so that then people can hear it. And then you've got the data to support what you need to do as far as policy. But all of that engine moves very, very slow, right? So the things that we want to see change, those things take time, where we have people that are struggling, that are dying, whose needs are not getting met, who can't get in to be seen, whose pain just continues to endure, right? Because hearing the stories and then getting action to be taken, those things don't just happen like right away. Like I can call Marie and say, Marie, I have this going on with this client, what can I do? And she can tell me some things, but there's still the systematic barriers that are in place that prevent folks from being able to get taken care of right away. And we just see that across the system.
I would say one more thing from a patient experience, and we're talking specifically about race because it's the month that we talk about race in America, so we're going to talk about race. But it's tiring.
It is.
To constantly have to be your own advocate, even at your weakest point. A fellow physician friend of mine, very dear friend, just got a major surgery. And she, as a physician, was having post-surgical complications. She called multiple times, and they did not believe that she was going through the pain that she was experiencing until I came to see her. And I said, oh no, this is valid. We need to be admitted. And it took us 4 hours to even get to a place where they would listen enough to, to check her out and to finally admit her as a Black physician in the place that she works. So I want to just be mindful that racism is much more than just individual experiences and biases. It transcends even socioeconomic and educational experiences of individuals. I myself almost died during birth because of because of lack of identifying my lived experience during the perinatal phase. And I was diagnosed much farther along in my experience because no one was willing to listen. So I think it's just very important that, having people that look like you in spaces within public health, policy, and in medicine, it literally makes a difference between life or death. And I'm sure every one of us can have a different story to tell when it comes to that.
And sometimes it even goes down to who you know. Like I said, I can call Marie, who's a doctor, who can then make something happen. Patients, clients, people in the community, they don't always have that. And so one of the things that we also have to try and expedite things for people is, again, we've placed community health workers. This is a very essential component of the workforce that we now have, because these are individuals that play a role as a liaison between the patient or clients and the organizations that provide the services. They almost hold hands. They go, they help people fill out applications. They make the phone calls. They help them get to the place. And then some folks are even on site talking them through things, talking with the provider through the situation that the person is in. I mean, that's the level that we're getting to right now, where someone actually has to go and be with someone, which is kind of sad. Again, they might have the insurance, but are they going to get the quality care if they don't have all these other things in place? A person in the community should not have to call the director of the health department to say, can you help me get to? The health director should not have to call a physician to say, hey, let's move this along. Something in the system needs to change so that people can be taken care of. Yes.
The whole system needs to change.
Yes.
In case you guys couldn't hear that, here at the front row, the whole
Exactly.
system needs to change, was the assessment. Right. Well, and we've, I think that the reality is that, and Marie touched upon this, the system that we create is the system that we pay for. So it is about codes. It is about roles. I mean, the community health worker work that Bobbie talks about is not generally part of the delivery of care system. It sits outside of that, paid for by, grants and programs. And what we know that from a clinical outcome standpoint, it's probably one of the best things to improve clinical outcomes, but yet we don't pay for it as a clinical service. So we've got a significant disconnect within the system. That was moderator discretion.
Okay, we're gonna go to a question online, and then the gentleman in the orange, and then you over there.
Okay, so from the online chat, we have a question. This is to any of the panelists. How much do copays and deductibles play a part in healthcare accessibility challenges?
I'll start. So I think it's very interesting because, again, I talked about how does the health system incentivize doing the right work. And so the way that the health system incentivizes, one way is by how you get reimbursed for the work that you do. So because Medicare identified that doing preventive health maintenance actually saves lives and reduces unnecessary, we call it utilization of the healthcare system. Now they said, okay, well, you don't have to pay a copay for an annual wellness visit, right? Annual wellness visit, for those who are not yet at the Medicare stage, that's like a well child visit, but for an adult. Okay, so like, you go in as a kid and you get your shots and you talk about like preventive care and all the things. That's what you do and you can do as a Medicare recipient. Those do not get copays. The problem is that how many things does an average adult have as far as problems when you go to see your doctor that you've been waiting for to see for like maybe 4 months? It's probably more than just preventive care, right? So the average American Medicare recipient has about 8 different chronic conditions that they are actively being taken care of at any point in time. And usually at a 15-minute primary care visit, we address typically 8 to 12 chronic conditions in that 15-minute appointment, okay? So the copay issue can sometimes come, hey, you're here for your annual wellness visit. We're gonna take care of your preventive care. Oh, by the way, doc, I have to talk about my diabetes. My depression is through the roof because my spouse just passed away. I need refills for my blood pressure medication. Yes, I did get my mammogram. Oh, by the way, I had a spot. Now you got to talk about it, right? And so you might go in for a regular visit that does not require a copay, but then when we talk about different things and we help to manage different things, again, we need to adequately and accurately communicate the lived experiences of our patient. And because of that, you might get a copay and nobody told you about it. And so the issue that we have a lot is that we have a lack of communication about unintended expenses. That's just outside of the hospital. But y'all tell me, how many times have you gone to the hospital to get, I don't know, colonoscopy done, and then you come back and you have bills upon bills upon bills that come to you, right, in the hospital setting. So there's a disconnect when it comes to that, these secret unknown charges that come up that we need to address.
Yeah, I mean, I think the unsustainable cost is tried to be sustained by making the payment systems more complex. And the more complex they get, the burden continues to get shifted to the individual person, whether that's more copays or a higher deductible or a high deductible health plan, which sounds great because you are in control of the money of a system that you can't control, right? So there have been a lot of incentives put into place that attempted to do certain things that I would argue implementation has fallen far away from intention.
And can I just comment, Marie? So I went to the doctors for my well visit and I could not talk about anything else. And so I may have had that preventative well visit appointment, but I was told I'd have to make another appointment if I had a problem. So there was no adding on the copay. There was just, you need another appointment.
Yeah. And how does that work for somebody who has to take 2 days off of work now? Right? I mean, that is the gap that we can't fill.
I also want to address it, well, as someone who not only a clinician, but also has to navigate the business end and directly interfacing with insurance companies. And I have found that there's a level of intention and in the confusion of the system. So I can call an insurance company and they'll say, okay, someone has a $20 copay. then they get what is called an explanation of benefits back, and it's untrue. They don't have a copay, they have a coinsurance, and they happen to have a high deductible. So now all of a sudden they're finding out, after having a service with me, that they have to pay the full costs of the service, because even the insurance companies don't always have the accurate information. And insurance companies are a bit duplicitous, because they will give you numbers. They'll say, call this number, it's a fax line, or they're like, oh, please say your name. You say your name, and then it just hangs up on you. It's wild, the things that you find out in the background, and it makes it inaccessible. And I cannot tell you how many faces I have seen in my practice who, when they recognize how their insurance is going to work for behavioral and mental health care, they have to either reduce their number of sessions or stop entirely because they cannot afford it. And then we also think about the system of Medicaid, which is supposed to be advantageous to people who have lower incomes. Small businesses like mine can't afford to take Medicaids because of how they actually treat the providers. And so it's just, as I want to be someone who services the community, I can't access all the communities I want to serve because it's not sustainable to the viability of my business and all my employees. So there's so many complex nuances to it about accessibility for clients, patients, and also accessibility for providers and how we can be accessible to communities as well.
Another question? I think she's coming right behind you.
Thank you. I have a couple of comments, and one, first of all, I want to thank you for your granular is the word, approach to the problems of healthcare, and congratulate you on your courage for doing what you do, which is nigh unto impossible. So I want to start with Ms. Sublette. I'm sorry, Dr. Sublette.
Nicole.
Nicole. The January, somewhere in the January issue of the New England Journal of Medicine, there is the first of a series of articles apologizing for a 150 years of racist articles in the New England Journal of Medicine justifying racism. And the first one was about race, and the second was about Asians. But it's pretty late in coming, but they're doing it, and it's worth taking a look because it goes way back. The other, I'm a retired doctor. My son's a doctor. His wife's a doctor. So I get a lot of these stories. But I'm the beneficiary of a lot of healthcare progress. But I understand that we're in a capitalist system, and money is a big force. So I want to, with that preamble, I want to ask each of you if you could wave a magic wand and change one major feature of the healthcare system, what would it be?
All right. Who wants to go first?
Well, I can go first for that one, and I'll keep saying this, and Joe, you already know this. My big issue is we do not have enough folks in our healthcare workforce to address the needs of all of the complex issues that we're seeing. I'm sorry. So we do not have enough healthcare workforce to address the issues that we're seeing, the complex issues that we're seeing, all the way from the mental health providers to the primary care providers, to the nurses, to the we don't even have like child psychiatrists, right, to address the issues that we're seeing with our youth in our communities. And our public health workforce, we got a boost in public health workers because of COVID. Well, now COVID's over, and guess what's happening? The funding that covered public health is now going out the door. And so that public health workforce is going to decrease. So we're in a conundrum because we're seeing increased issues across the healthcare spectrum, chronic diseases, substance misuse, mental health issues are just all over the place. And so magic wand, healthcare workers, pay people salaries that they can afford to live off of as well as they're providing these services. Make it easier for healthcare workers to actually stay in New Hampshire instead of going across the border to Massachusetts.
Nicole or Marie, either of you.
I think if I could wave a magic wand, it would be, which one of my wands do I wave? I think having a system that requires less clicking and more talking, I think that would be great. We have electronic health records, for instance, which has been a good advancement in documenting materials, but they don't talk to each other. You can be on the same electronic health record in your office on the outpatient side, but it doesn't talk to the hospital on the inpatient side. And so I still don't have all the information I need. And as a very jealous family doctor, I don't like not having the information I need for my patients. So I think having a system where I can just talk with my patient and the bill's there, right? Like it just appears, as opposed to me who hasn't gone through, school to be a certified coder and biller, now having to learn another language just so my patient can have their story expressed. So,
Nicole?
I think for me, I would like the erasure of oppression. I think that we oftentimes, as people, whether it's physically or mentally, we're just pathologized and we're seen as a system of problems. And I'm tired of being seen as a problem, and I want to be seen for my wholeness, and I want to be seen for my humanity. And if we could have that one where we're actually listening to each other and connecting through our humanity. We're not a medical record, we're not a F code, Z code, whatever the ICD-10 wants us to diagnose with. We are humans. And at the end of the day, if we can just connect on a human level and see each other and listen to each other, that's what I really, truly, truly want.
Great.
Hi, my name is Sonia. I'm also a family physician, so I really resonate with what you're saying.
no family doctors.
Nicole, I wanted to say that when you were telling your story, I felt like there was like a witnessing that was happening, so I'm really grateful to you for that. The question is actually kind of similar to the prior one, but it's the sense of that our healthcare system hasn't been designed. It wasn't designed. We sort of inherited something that's been piecemealed together, and Joe was talking about the value or the importance of policy. And so because you have an attentive audience that is engaged and possibly active in the political realm, what's a vision that you have? If you can think of the patient experience and what the experience of the healthcare system, what vision can you offer for design that would be like kind of what we could look towards? Yeah.
Ooh, redesign.
Design.
Go ahead, Bobbie. You're leaning in.
A redesign. One of the, Dr. Ramas mentioned the electronic medical records not communicating. We also have a problem where we just can't communicate to each other, period. We will know that we're working with a complex issue with a client, but Nicole can't talk to me. I can't talk to Dr. Ramos. We can't even talk to each other. So we have systems in place where even though we're trying to work on the behalf of the client, we can't even forget the medical record. You can't even tell me certain information, right? And sometimes we'll find folks in situations where they desperately need the support and health, and that block will be that we can't talk to each other. So we have to do something policy-wise with being able to share information. In public health, under RSA 141, there's certain information that I'm supposed to be able to get, but I'm still not able to get certain information or share information because of patient confidentiality, even though we're working on the behalf of the same patient. So if there's something that we could do around there, yes, protect people's confidentiality and anonymity, but some kind of way we need to be able to talk to each other without having that as a block.
Marie?
So as Granite Staters advocating for increased funding for recruiting primary care clinicians, whether that be mental health services, direct like primary care services, psychiatric and behavioral health specialists, providing increased funding for loan repayment for them. That's like a very practical and evidence-based way of recruiting and retaining workforce in the Granite State. And so any opportunity you may have to advocate for that, again, primary care, we save y'all money. So I think that would be huge. The second thing I think that would be helpful to advocate is to just share your stories of how difficult it is to just be seen. The average legislator in New Hampshire does not have the same lived experience as most of us in the room here. And so sharing your specific stories, whether it is written and sharing that online or coming in person to Concord, that actually makes a difference with many legislators. You are the expert of your experience.
Right, Nicole?
So I also sit on the board of directors for NAMI New Hampshire. And so I often see things that come through like House bills and such. And again, what I think about is, once again, such as the Divisive Concepts Act, where we can't talk about fundamental differences, we can't talk about race, we can't talk about identity, we can't talk about sexuality. And so if we are talking about things like what Maria was talking about, epigenetics, and how that plays a part in the body and how DNA is altered through oppression and discrimination, and those are things that we all face to some level, right? We all have aspects of power, right? We all have aspects of privilege, and we all have aspects where we've also been oppressed and marginalized. And so I think it's really advocating, again, as people advocating for humanity, because oftentimes in our political system in this state is often trying to take away the humanity and freedoms of people just to live and to be themselves. And that has a huge impact, and that's literally killing people. Whether it's people taking their own lives, because NAMI, we talk about suicidality all the time, or because people are dying early because they're experiencing weathering and discrimination, or they're just not being taken care of at all.
Yeah, and I'll just add, I think, several years ago, I was on a panel with somebody who was from Consumers Union talking about health and health policy. And she brought up this point, which is everybody thinks somebody is watching the store when we think about the healthcare system, and nobody's watching the store. And so I think this notion of figuring out who could be responsible for watching the store and have that kind of oversight to ensure that these things that we all identify as problems, whether those are historical, well-intentioned policies around privacy and confidentiality that have simply become barriers because when they were created, the system that we have today was not a thought. I think those are the places where we continue to have these conversations around, oh, I thought somebody was supposed to do that. I thought somebody was responsible. Isn't somebody responsible for that? And everyone's sort of surprised, like, no, sorry, you're on your own. And when you can't bring your family doctor into the hospital with you, it becomes your family's responsibility. And I think we all know that feeling too.
We just only have time for one more question. I know there were many hands. So last question.
I warned you all would be deep into this in the beginning.
Everybody keeps talking about the lack of supply, and I know that as a patient, particularly with primary care doctors, and I'm just wondering if you span out a little farther from the state level, what should be done at either the national level or the licensing agencies for medical providers that may be intentionally limiting the supply or rewarding people who specialize? How might that be fixed at different levels?
Marie, may I ask you to start?
Yeah, sure. That's a great question. So there are a couple of things that have created bottlenecking. So I'm going to start with a positive. For the last 5 years in a row, family medicine residency programs have fully matched year in and year in and year in. And there's been more and more medical students interested in family medicine. The reason I focus on family medicine is because we're family doctors, so we always will go into primary care. That's not always the case with internal medicine doctors that might start off general, but then they specialize and it can get a little more muddy. So primary care and putting funds in, we call them GME funding. And so one of the positive things in New Hampshire is that we now, instead of having just one family medicine residency program, we now have 3, and we're going to have 4 family medicine residency programs in the next couple of years. That's huge because residents, where they go to residency, they tend to stay and practice there. So that's one way of increasing the primary care workforce. The second is one that I already discussed, which is loan repayment. The average physician that comes out of medical school has about $300,000 of debt. 300. So the loan repayment programs that states are able to provide, that private entities are able to provide, and then there's a public service loan forgiveness program that helps for clinicians who are interested in serving in historically minoritized populations. That's another way of recruiting, retaining, and helping to reduce stress and turnover. The second thing is the third thing is creating work-life harmony. So one thing that COVID has shined a light on is, again, the humanity of clinicians. Many clinicians left their love in practice during COVID because it was such a demoralizing and dangerous situation, and they did not have the resources they need to practice safely. They just left. So the clinicians that maybe they were in their 60s, they still liked to practice, but they didn't want to deal with all of the drama and bureaucracy. They just left. And some clinicians that were coming out into residency, instead of going into just general primary care, they decided to go into niche practices. And so we're starting to see this trend, which I think is for the positive, of the prioritization of personal well-being as clinicians, and that also will help with the longevity in practice that I think we need. And then the last thing that I would say is supporting independent primary care and community health work. So our federally qualified health centers, our rural health centers that are more interdisciplinary, those are spaces where you can meet mission to margin and still maintain joy in practice and have a measure of autonomy to think creatively that I think we sometimes miss opportunities in.
Great. Can we get, I hope we can just take a minute and ask Nicole and Bobbie to answer that question too, because I do think we hear a lot about the lack of qualified mental health providers in the state. So Nicole, I want to make sure we have an opportunity to hear from you on this issue too.
So there are things being done in the mental health field, like compacts, which are allowing people to practice in different states, because every state has a different governing board for licensure, which can create barriers. And so when we're looking at these compacts, we can really open up access to care. I think that's one thing that we can do, but I always go back to, I really align with what Marie's saying also about the education piece, because education can be so prohibitive and it can be very hard to get into, whether it's primary care, becoming a therapist, whatever it may be. It's not accessible to people. And we talk about a lack of workforce, but I think what it really comes down to a system of inequities. It comes down to who has access to afford education. And if we can make education more affordable, then we can have more providers providing excellent care. We can have more diverse providers providing care, because I know in psychotherapy, psychology, only 4% of providers nationally are considered people of color. 4% nationally.
Great. Thank you, Nicole. Am I turning the floor over, or do we?
Turning the floor over.
I would love to, I can stay for a little while longer and talk after this, but we got to give the floor back.
Yeah, and I will say you are turning the floor over, but certainly the conversation should continue. And I want to thank the panelists for all they've imparted today. And just because this is an opportunity to say their names, and they are here to hear their names, let's do it. For Bobbie Bagley, Dr. Marie Ramos, Nicole Sublette, And I'm going to say Josephine, because you said only when you're in trouble, but you started trouble when you started this. So Josephine, Joe, thank you. Okay. Oftentimes I try to wrap this up by just a few points that I heard that really stand out, but today I found I couldn't do it. So what I'd like to do, if you bear with me for maybe 3 minutes, is just a few words and or phrases that have come out today that really hit me and kind of tell me, and I hope you also, what we should do next, or what we should take from this room, because there was conversation, the tea was spilled, and we need to do something with it. So some of the words that hit me: access, 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 barriers, lack of trust, language, systemic barriers, a la carte systems, 7 minutes. Medicine has become a commodity. We need disruptive innovation. Family doctor, your family doctor is your doctor who knows you, who should know you. So what are we to do? Advocate for more family doctors, family practitioners, GPs, and I'll throw DOs in also, okay? Policies, vulnerable versus privileged, power differentials, systemic racism changes DNA. Importance of active hearing and listening, access. Having people who look like you can make a difference. And with that said, I don't want it ever to be said that we are not doctors. There are at least 3 people of color who are physicians and or in the medical practice in this room today. Okay, there is a difference. Having people who look like you can make a difference between life and death. Access. And finally, the whole system needs to change. Okay? So, I want to thank, first of all, the Black Heritage Trail of New Hampshire for having the insight to put this program together and for reaching out to the professionals that they reached out to, and for the professionals saying, yes, this was important enough to come out. I want to thank all of you in the room, all of you who are here virtually, and all of you who I know heard something this week that made you think, I'm going to invite someone else to this next week. So, next week we have, what do we have? February 25th, same place, same time, close to the edge, policing, policing and criminal justice in New Hampshire with the panelists John Schippa, Detective Rochelle Jones, and the Honorable David Ruoff. But today, again, I want to thank everyone here, everyone listening, everyone who thought to listen and be here and couldn't. And also, we have to thank our sponsors, without whom we couldn't do any of this. So, I am thanking today, one, aren't we comfortable here at the Portsmouth Public Library? Also, New Hampshire Humanities and Mass General Brigham Wentworth Douglas Hospital. So thank you all, and see you next time.